Thank you. Let me first thank Dr. Kobashigawa, because he's one of the pioneers that collaborated with the company at a time we were probably 10 employees, and we had this idea that we could use gene expression to kind of find a better way to look at heart transplantation and rejection. And it took a lot of vision to really start working with us and developing the product that we have now. The product, as John indicated, is a non-invasive gene expression test. We have 20 genes in the test. 11 are used to distinguish quiescence from rejection. 9 are used to normalize and do quality control on the sample. We measure the risk of rejection in heart transplant recipients. This is how we report back to the physician. We provide a score from 0 to 40. The higher the score, the higher the risk of rejection. Lower the score, the lower the risk of rejection. And we also provide the previous results as well as the interval of confidence so that the physicians can actually look at the evolution of that particular patient and use eventually, if they want to, the patient as its own reference looking forward. John indicated that one of the main challenges now for heart transplantation is really to manage, keep the patient in balance between rejection, which would naturally occur, and the immunosuppression that is provided to avoid the rejection. And it's very hard to find the equilibrium where you have low or no risk of rejection, which would lead to graft dysfunction and graft failure and death, and also maintaining as little as possible immunosuppression to avoid the side effects, which are multiple and very serious associated with immunosuppression. Too much immunosuppression would lead to cancer, to infection, would lead to organ toxicity of the liver, of the kidney. It happens with some regularity that heart transplant recipients who are 10 years out will then need to have a kidney transplantation because the immunosuppression has actually destroyed their kidneys, as well as metabolic disturbances. So the challenge really is to avoid rejection, because physicians have been extremely successful in avoiding rejection, but minimize immunosuppression as much as possible. And that very delicate equilibrium is hard to achieve with only clinical symptoms. And this is why physicians have been using endomyocardial biopsies, which is a procedure, as John indicated, that enables them to take samples from the heart and look at them under light microscopy and assess whether or not there are signs or visible signs of rejection. But by nature, what they're looking at is cellular destruction, which is way too late, and this is why they wanted to have something better than that. As John indicated, it's first very invasive for the patient, but most importantly, it's something that is very subjective, because at the end of the day, it's a pathologist looking at those samples under light microscopy and trying to figure out whether or not they can see signs of cellular infiltration. And as John indicated also, this is rather frequent, so there are about 20 to 35 biopsies per patient in the first 5 years post-transplantation. It's a rather expensive procedure. The side effects are quite complicated. One of the very frequent side effects is tricuspid regurgitation, meaning with the repeated passage of the bioptome, which is the catheter that is inserted through the jugular vein all the way into the right ventricle, it happens that the tricuspid valve would be damaged. And when this is done several times, there would be then tricuspid regurgitation. That means the blood flows back. And that leads to either some additional therapeutic regimen or sometimes valve replacement, which is very expensive. The other element that we are now paying more and more attention to is the fact that in order to insert the bioptome all the way into the right ventricle, you need to have an imaging system, which is usually the fluoroscopy. And fluoroscopy is an X-ray machine, but it's the same difference between a photograph and a movie. In a photograph, you have a snapshot, doesn't expose the patient to a lot of radiation. With fluoroscopy, you literally light up the patients for 1 minute to 2 minutes to more time at once. And so you have very significant amount of radiation that is inflicted on the patient. And remember, these are immunosuppressed patients, so it's not a very good thing to do. And of course, there are rare but serious other adverse events, such as perforation of the heart, perforation of the lung, tamponade, and other complications. So for all these reasons, we felt that developing blood test would be a very good solution. It would provide an objective measurement for the physician. It would provide a non-invasive alternative for the patients, and it would also would be cheaper for the payers. So we developed that test, as John indicated. We started in the year 2000. We launched the test in 2005. We launched it as a CLIA developed test, and then proactively, voluntarily went in front of the FDA and obtained a clearance. So far, we've performed 34,000 tests on about 9,400 patients. And as John indicated, we did a study started in 2005, published in 2011, where patients were randomized into one arm managed with AlloMap and the other arm managed with biopsy, and we looked at outcomes to see whether or not AlloMap was actually providing the same kind of outcomes as you had with biopsy. So from there, that's the study we just talked about, which was published in the New England Journal of Medicine, which we believe was absolutely critical in order to help physicians adopt the test. Jean indicated that the test is being considered for routine use, and it is used in routine by a number of physicians, but not by all. And we felt that this particular outcome study would actually help them appreciate whether the test was effective or not. Once we had this study published in the New England Journal of Medicine, we then had the test, and then we say we, it's not we Xdx, it's actually the Society of Heart and Lung Transplantation evaluated the results and compared it to biopsy and decided to include AlloMap into their clinical guidelines. From there, we obtained a recommendation from the California Technical Assessment Forum, which is a foundation sponsored by Blue Shield of California, which looks at technologies, evaluate them, and makes recommendations to cover or not. We had a positive recommendation from CTAF, which then led to Aetna, and followed by last year 16 other insurance to make a decision to cover the test. We didn't stop there. As John indicated, he's actually conducting a study now in the early part post-transplantation, which is really a very critical time for heart transplant recipients where the risk of rejection is the highest. And he's looking at whether or not he can use the test to wean corticosteroids faster with AlloMap, and hopefully will be able to provide further help and further clinical utility for the patients and for the physicians. That particular study, New England Journal of Medicine, was really what triggered all the series of good news for us. We then went into the guidelines, we went into positive coverage recommendation. We went from about 50% of patients covered by insurances that paid for the test to now 67% as of January 1st, and we think that's going to continue to increase very quickly, as well as being paid much more often. So here is the summary of what we did. First, we had a very rigorous validation of the test through the clinical studies, and we wanted to have a test that had a very high negative predictive value, meaning that because when there is a rejection, there is a risk of death immediately for the patient, we wanted to be absolutely sure, as much as we could, that when we were saying the patient is not rejecting, meaning the physician will not do anything to that patient, we were absolutely sure. So we traded a very high negative predictive value for a relatively low positive predictive value, meaning when we say the patient is not rejecting, we're very sure of that, 98 to 99%, depending on the time post-transplantation. Versus when we say there is a higher risk, it only means that there is a higher risk. That doesn't mean the patient is actually rejecting. So that was a conscious trade-off we made to address the need that the clinicians, and in particular, Dr. Kobashigawa told us right at the very beginning, he said, the one thing you cannot do is you tell me the patient is not rejecting, I send the patient home, the patient dies from a rejection, not acceptable. So we really traded the performance characteristics of the test on that. I mentioned already we've performed so far 34,000 tests for 9,400 patients. Just to give you an indication, there are about 21,000 living heart transplant recipients in the US, so about half of them have already been tested with the test. And of course, I failed to mention that, but the test is used repeatedly. It doesn't replace completely biopsies, but it replaces the biopsies that were scheduled for patients who are feeling fine. Of course, if the patient presents with symptoms, the physicians will have to go directly into treatment. From a regulatory standpoint, we did like everybody else. We developed the test in our own laboratory. We got clear certification, but we also decided to go in front of the FDA. The reason for that is because we are the only one performing the test. We felt that in order to give more assurance to the transplant cardiologists that the test was actually properly validated, we felt it would be useful to go in front of the FDA, which we did, and obtained clearance in 2008. From a reimbursement standpoint, we were fortunate to obtain Medicare coverage very early on in 2006, retroactive to January 1st, 2006. And this has worked very well for us, but for the longest time, we could not get the private payers to cover the test. Medicare represents about 40% of all heart transplant recipients, or covers about 40% of all heart transplant recipients. But since the New England Journal of Medicine publication, we've been able to get good success with the private payers. The other factor that was absolutely essential for us was to be written and recommended into the clinical guidelines. That was really a tipping point for us in terms of adoption and coverage. And finally, in terms of outcomes, while we have already done one study that compares the outcome in terms of death, survival, acute cellular rejection, or hemodynamic compromise for patients, we're now looking at other outcome study because we believe, again, that that's the way to increase utility of the test, particularly when it comes to helping the physician make decision to reduce immunosuppression. So I'm going to wrap it up with this, and this is really one of the main challenges that we've had. One of the factors that played very strongly in our case was the fact that biopsies are performed in the cath lab, in the catheterization suite. This is a revenue-generating activity for the hospital, significant source of revenue. So when you have a test like ours, which is non-invasive, no radiation, much more objective, cheaper, you would assume that would be a no-brainer, that it would be taken by storm. That was not the case because, particularly for hospitals, that meant losing revenue from a rather profitable part of their hospital. So we've had really a challenge there, and I tip my hat off to leaders like John Kobashigawa, who has actually done what was right. He studied the test and made his own mind and decided to use it. Which is not an easy thing to do because, again, the economic incentives are misaligned in this particular case. And I'm talking just one-for-one comparison. I'm not even looking at the cost of all the adverse events that are associated with biopsies. So I think it's also time, as Dr. Ralph Schneiderman was indicating a little bit earlier, that we start looking at the global picture, and we also align the incentive, the payers begin to align the economic incentive for physicians, for hospitals, to really pay for performance and outcomes. That's really what matters in the end, and that's going to be cheaper in the long run rather than the actual view from the payers, who tend to believe, at least that was my experience, that if they say no, they'll save money and therefore they'll be in good shape. And this is why innovation is rather difficult to bring into healthcare. So again, for me, the outcome study that we've performed are not just a nice thing to do. They are the only way for us to move forward and to get the payers to realize that this is actually saving money, and they should not just cover the test, but begin to look at the actual overall compensation and the economic incentive in heart transplantation. So I thank you very much for your attention.
Merci beaucoup.